Welcome to the ODP cast, the podcast all things ODP. With this podcast, we will attempt to inspire and educate and hopefully get a few laughs along the way. We'll be covering many different topics relating to the profession, such as what's new, some around education, some around research, and many, many more. We'll also be doing some reaction videos to some of the funny videos that we've seen on the internet, so make sure to follow us on YouTube so that you can see what we see. Tune in to get updates, get involved by following us at ODP Show across all major social media platforms, and remember to save this podcast to keep up to date with myself and our many guests as we add a little Yorkshire twang to the fantastic profession that is operating department practice. Welcome to episode 4 of the ODP cast. Today's topic is the role of the Anaesthetic Associate. So a lot's changed since we last recorded, hasn't it, Jenny? I've got a new surname.
Technically, it is Christmas. I'm wearing Christmas.
It's Christmas.
It's Christmas.
I needed to up my game, so I went to Poundland.
So luckily, we do in fact have an expert in the room. Do you think that gave you any advantage as an anaesthetic associate? How do they become one?
It isn't an extension, it's an entirely different role. If you're thinking about doing this for money, forget about it. So we undertake lots of different aspects of anaesthesia, and we're quite an adaptable bunch, I think.
Jack of all trades, then.
Yeah, it's another one of these roles which is easier to tell you what I don't do than what I do.
Like, what is, like, let's say just a typical day, what would you do?
You will be just as good.
Anaesthetic Associate, let's do that.
Welcome to episode 4 of the ODP cast. Today's topic is the role of the Anaesthetic Associates, and I'm going to introduce some of our fantastic guests. So, who wants to go first? Don't all jump in at once.
Shall I go first? Hi, I'm Jenny. I'm senior lecturer at Sheffield Hallam University.
Hi, I'm Ben Law. I'm a lecturer at Sheffield Hallam University, ODP by registration, but actually teach on paramedic science. I'm sure we'll explain that a lot more later.
We will. We'll go into it. And our special guest, drum roll please.
Hi, I'm Brian Corrin. I'm a lecturer at Sheffield Hallam University. I'm also an Anaesthetic Associate, originally an ODP.
Fantastic. Thank you all for joining us for this episode of the podcast. I have also realised during the editing phase for the first few episodes that I'd never actually introduced who I was. So I introduced my name, but I didn't actually introduce what I did. So my name is Christopher Ellis, and I am one of the ODP lecturers at Sheffield Hallam University. So a lot's changed since we last recorded, hasn't it, Jenny? I've got a new surname.
Technically, I've got a new surname, though it's not on here. I've got a different hair colour. That's the most important thing that's changed. It is Christmas. I'm wearing Christmas.
It's Christmas.
It's Christmas. So we're in our Christmas garb. Yeah.
What's your new surname, Jen?
My new surname, funnily enough, is Law, because yes, my husband is Ben Law, who's currently sat in the kitchen while I am sat in the office in the other room. So yeah, we are in the same house.
We've all known each other for a while. I used to work with Ben in practice, didn't we, Ben, for a little bit?
Yeah.
Many moons ago.
Yeah.
The ones.
So it is officially December. So what's everyone getting up to for their Christmas plans?
Probably. I think we're hosting this year, so we're going to have Christmas at our house with the family. Normally on Boxing Day we have a big celebration with our friends, and I think it's Robbie and Chloe's time to host. So we're going to go and see them on Boxing Day. Quite a chilled one. Nothing much going on.
Yeah, we did the joys of hosting last year, so we're definitely palming that off this year.
At the Boxing Day one, yeah.
The Boxing Day one.
What about you, Brian? What are you up to for Christmas?
I'm going to be hosting again, hoping for a big house full. So love a bit of cooking. So can't wait, to be honest. Feet up, normal stuff. Bit of lots of food, couple of drinks, lots of movies, chilling out with the kids, family. Be good.
Yeah, it's my birthday coming up. I'm going to be 31. So that's coming up in the middle of December. And for Christmas, we usually drink a lot of Bucks Fizz. eat a lot of food. Usually watch the Gavin and Stacey Christmas specials, previous ones, but there's a new one, isn't there? So that should be
Oh,
exciting.
yeah.
Mm.
Yeah.
But no, thank you so much for agreeing to come and do this podcast. So what I'll do is I'll jump into the topic of the role of the anaesthetic associate. So luckily we do in fact have an expert in the room, as I'm sure you've got from the introductions. So I'm going to start by opening up the question. This can be to anyone. What is the role of the anaesthetic associate?
So it does vary from trust to trust. I think the role, I mean, it's been going since approximately 2008 when it was first introduced to the UK, and that seems to take a lot of people by surprise. And the role was developed for essentially working with the sort of more fitter, healthy population within healthcare, and it was a model taken from Scandinavia, Europe. There are similar roles in America, although they're slightly different. And the idea being that this sort of non-medical anaesthetic role is there to help with what I'd sort of call the day-to-day sort of bread and butter, like I say, the sort of more fit and healthy routine operations that doesn't necessarily require a consultant. NAA works with a consultant always, so we're always supervised by a consultant. The training has developed quite considerably over the last few years. Initially, it was just run through the University of Birmingham. Training's now expanded to include University of Lancaster and UCL in London. And along with registration, which is just on the horizon eventually after years and years of debate talking about it, then so what's happening essentially is it's going through quite a change, is where I'm going with this, and the syllabus and the types of things that we do is changing and has changed quite considerably. But I think if you were to sort of paraphrase it, we do general anaesthesia, some do regional anaesthesia, upper limb, lower limb, some do spinal, neuroaxial anaesthesia. AAs also work in sort of day case, they work in main theatres, some do some more out of hours as a supportive type role. I think on the whole, we tend to work either one-to-one with a consultant. So that might be where lists are perhaps prone to lots of changes. So for example, trauma. So we're sort of able to sort of facilitate that sort of very fluid environment. Or the other alternative and frequent way in which we use this, we have sort of what we call a 2-to-1 model. So it's 2 anaesthesia associates with 1 consultant anaesthetist that oversees both lists. So we undertake lots of different aspects of anaesthesia across lots of different disciplines, but yeah, I think the role is very much developing and it varies from place to place throughout the country.
Jack of all trades, then.
A bit of a jack of all trades, yeah. I think, you know, some guys do some stuff up and down the country, which, you know, I just don't do. And it's pretty cool. Some of it is, you know, some of it, yeah, I do. And it really does, it varies quite a lot. And I think, you know, that's one of the benefits of the role, because if there's a need within a geographical location for a specific skill set, or looking to take our skill set and sort of develop it to the sort of local environment, then we're quite an adaptable bunch, I think, would be my sort of general take. That answers your question.
Do you think, I mean, it's quite a difficult remit even for like describing the role itself. Like say, if geographically there's change depending on need, depending on what that trust requirement is in that local area, it's then quite difficult to standardize what training is required, I guess, because I'm sorry if I'm stepping on questions Chris has got later, but I imagine there's then differences. Now it's moved from being that centralized one university to there being multiple centers, that actually is there difference in training depending on geographical need in the areas? Right.
So it's a really good point, Ben, and it's one which is being addressed now, and it sort of falls into, you know, the fact sort of in terms of the history, 50% of AAs are approximately biomedical science graduates. So you can get into being an anaesthesia associate either through a biomedical science graduate or from a clinical background. More often than not, they come from an ODP background, but there are nurses and other healthcare practitioners who've made it into becoming an AA. And I think the numbers are still quite small. So as of today, we're still only approximately 230 odd throughout the country, which is absolutely a tiny amount, most of which have pretty much all exclusively come from Birmingham. But what's happened is because they've been used in different trusts in different ways to fill a particular need. The basic training is just the basic training, and then what's happened has been lots of sort of local extra training and governance and standard operating procedures. So part of the registration is about sort of standardizing that. So the GMC have been very heavily involved, as have NHS England. The GMC is going to be the regulator for us, which I know that's caused some controversy, but nonetheless, that's the way it's going to be. So I think because it has developed, it is a really, it's a very prudent question to ask. I think on the whole, things have been very sort of standardized, but it is an area that we do need to sort of address as a group of us throughout the country, for us individually, but most importantly for patients, for service users and those who are looking after us, i.e. the consultants.
I'm quite surprised, Brian, that you said that there's only 230. For some reason, I just assumed that there were a lot more than that.
No. So all of this fuss over 230 of us stealing a load of jobs. But anyway, let's not get started about that.
So, because one of the ways that I describe it, because it's sometimes some of the stuff working as an ODP lecturer in recruitment, sometimes people do come to me and ask about the anaesthetic associate role, and I usually sort of break it down to split up the ODP role is where the individual that assists with somebody giving surgery, and then anaesthetic associates can give the anaesthetic, and that's in a sentence what you kind of explained in 10 minutes, but I could be wrong. I apologise.
How to sum it up into in a neat package of like a few words. Yeah, it is tricky, and I think that's probably what we struggle with the most. And like the amount of questions you get asked about it, and like it is so difficult to explain because of the differences within each area. And your explanation of it, Brian, can be totally different to someone who did it in 2008 and did it in Birmingham and are now doing it elsewhere. It's like what their actual scope of practice is and what they do within that could be vastly different. So then trying to, but that's, I guess, the same as an ODP. Trying to explain what an ODP does from one end of the country to another is actually really difficult to sort of pin that down, and it's kind of another sort of element to our role and our scope that builds off what we're doing and what we already know, and sort of allows us to sort of develop there. But it is very much dependent on where you are, what your training is, what your employer is doing with them. So I think that's the problem with it. It's really difficult to kind of pin it down into a anaesthetic associate, let's do that, like, the tagline element of it. It's really hard to have that with it, from what I can gather anyway.
It's another one of these roles which is easier to tell you what I don't do than what I do.
That's a good way to put it. So for any listeners out there that are thinking about taking a role as an anaesthetic associate, how do they become one? So what's the typical pathway? Can you just apply to university for it, or?
So currently as it stands, you can't just apply to enroll on a course. As I said earlier, there's 3 courses, there's 3 institutions throughout the UK that offer the AA training. You need to be employed by a trust. So essentially it comes along as a trust will decide that it wants to have X number of positions. It will then put those out as a learning, an employment, a temporary learning contract. The universities have their own criteria, which are, as I said, biomedical science degree or science graduate, and or a clinical experience of 3 years plus clinical experience in a relevant area. Each hospital will have its own interview policy, as it were, in terms of how it selects them, but essentially it then puts forward to the university. The idea of the 3 universities, Lancaster sort of cover the north part of the UK or England. Birmingham obviously would sort of carry the Midlands, and then UCL looking after the sort of the southernmost hospitals. So I work with and know, and we've taken on biomed science grads with zero experience who have performed particularly well. I think we have quite a robust interview day, is what I would call it. I know UCL also has a test which they want candidates to go through, again in terms of a suitability. So it is, we do come from varied backgrounds. I think there's this view of sort of being from ODPs, and I think understandably, I think the first few that came into the UK were from an ODP background, and although I don't know for sure, I suspect that was because of a security of, this is a group of people that consultant anaesthetists know and work with and understand their ability, their knowledge, but also their limitations. So there is sort of two distinct paths. But as I also would say, I work with, again, a couple of numbers of nurses. There have been midwives who've made the jump into Anaesthetic Associate. So it's quite an open spread. It is extremely competitive. The trusts where I work with, we have had, having sort of gone through the whole selection process and helped with that on a few occasions, if we've had 3 posts, we'd be talking at least 80 to 90 applicants just for 2 to 3 posts. So it is extremely competitive, but the pool that we can take is quite considerable.
How long's the training?
So currently it varies a little bit. So Birmingham's 27 months. So, and you get a postgrad diploma. UCL is a couple of years, but they do it as a master's. And I believe that's very similar to how Lancaster do it as well.
No, I'm just thinking back. So, because I just was doing some weird math in my head, and I was thinking, you said that in 2008 is when it first started in Birmingham. I was doing my training in Birmingham 2009 to 2011, and that's when I first were introduced to Anaesthetic Associates and worked with them. So I was just thinking to myself, oh, I must have been working with them when they were like brand new, like it was never done before.
Yeah.
So yeah, and I used to work with them in a orthopedic hospital. And yeah, it would be the 2-to-1 model, as you were describing earlier. There'll be 2 anaesthetic associates with 1 overseeing consultant who would sort of, weirdly enough, we in the hospital I worked at had those really old style I can't remember what they were called, but they were essentially theatres that were back to back, and they were all open except for there was one partition wall that wasn't a full wall between, and there was, I think they were like barn
theatres, was it?
Barn theatres, yeah. And it was basically, you had one scrub up area, one like prep area, but 2 theatres, and it would all like link together, and the consultant would literally just be wandering in between this partition wall between the 2. Yeah, so I must have been working with some of like the first ones in the country. That's quite nice to
you would have been, although you've just reminded me, I think there were a few that were before that, but 2008 approximately was where it got some traction. But
because there was the physician's assistants as well that would like physician's assistants that trained then in anaesthesia. I don't know whether that's the different.
So this is another part of the history of the Anaesthesia Associates. So my qualification was physician's assistant in anaesthesia. So that and which is a bit of a mouthful at the best of times. But you're right. So that was how it started. It was called a physician's assistant in anaesthesia.
So Brian, you're a physician's assistant in anaesthesia, previously an operating department practitioner. Have you got any letters left that we need to add in there? Like, that's one.
You want to see that all at the end of your name, when you put it on emails, all of those letters just.
I want to see it. I want to see it on a railway sign like that one in Wales.
Yeah, BSc.
It's impressive.
I remember it being called a PAA. I think when introduced to you, Brian, when I was a student many years ago, I think you introduced yourself as a PAA.
Yeah, the Anaesthesia Associate is a relatively new, and this is where it's sort of fitting in with the medical associate professions, of which sort of physician associates is a large cohort of thousands across the country. And I think this is where there's potentially a little bit of confusion about the name. But so the Anaesthesia Associate role or name was adopted just a few years ago. Prior to that, anyone who's done it was known as a PAA or physician's assistant in anaesthesia.
So I suppose that kind of linking back to what you were saying before, having that registration then and having that term that's then yours as a professional group will then help to build that profession and sort of build the what's the word I'm looking for?
Identity.
The identity, or like how it's seen within the area, because then you do have that differences between the PAA and the AAs and what each individual do, and the differences then with other physicians associates that are physicians associates in something else, not in anaesthesia. Exactly. So
exactly. And I think it is confusing, and I think again that's one of the areas that we need to sort of clarify. But as things are, I mean, if we think back not many years, ODP wasn't a profession, it wasn't a registered title, it was.
Don't get me started on the history of ODP. I could talk to you for hours about that.
But even anaesthetics, even anaesthetists was not a registered title for many years. It's still relatively new in a sense of medicine. They were under the auspices of the Royal College of Surgeons, I believe. So with this, being around, I talked about 2008. There were a few before that, but yeah, so it is in its infancy, but part of we need that identity, we need that name, we need people to know what we do, and that I guess fits with the whole sort of training and regulation of us as a profession.
So can you just describe to me then, Brian, what is a typical day in the life of an AA? Like, what is, like, let's say just a typical day, what would you do?
So typical day, well, you'll know what lists you're doing on your rota. More often than not, you'll have done all the pre-ops in a time before. It's quite nice to at least do them a day or two in advance when you've got a minute. But I would come in, grab a list, just make sure there's no changes. Where I work, it's all computerized, so it's quite nice. I can sit at home and sort of access and go through things that I need to go through to sort of prepare me. But essentially get in for sort of 6:30-ish, go and see the patients, however many patients there are for that particular list. As with anything, once you sort of, if you do the same thing frequently, you understand the surgeon, you know how long they're going to take, you know what the procedures are. So with that sort of experience, you've got a good idea of how things are going to go anyway. So go and see the patients, go and essentially do a preoperative assessment. That will be taking a medical history. So we're going through comorbidities, medications, allergies. We'll do a full airway assessment. We'll then talk about and consent for the anaesthetic type, whatever that may be. Again, with sort of experience when you're working with consultants on a daily and weekly basis, and how each other works. But then I would go and sort of talk to the consultant and talk about patient A, present them as they are this number of year old, they're coming for this, they're having, you know, they again run through the comorbidities, run through past medical history, run through, and then talk about the anaesthetic options. I think your consultants there, if you've got anything that's particularly tricky or unsure about, you know, and that could be a weird and wonderful syndrome that you've not particularly heard about, or you might have heard but you don't know much about because it doesn't crop up very frequently, or if you've got concerns with anyone. So once you've got your plan in place, agreed, you go back to theatre, you start to get all your drugs ready, and then you'll have your team brief, as everyone will be familiar with, and then start the list. And that will be doing, you know, everything from IV access to then the anaesthetic itself. And you're with that patient until the end, taking them to recovery. Consultant will sort of do all of the post-op meds. And then between you, you'll review them, and then you know, you rinse and repeat really for a morning list or an afternoon list. And it's quite nice to then go and see the patients if you can a bit later on and see how they're getting on, and before they hopefully go home. So it starts early, it finishes whenever it finishes, and you undertake all aspects of that anaesthetic.
So then
There's, well, sorry.
Go on, sorry. No, go on.
I was going to say, so there's a warning for all of our listeners and students listening here. It's an early start and it is a late finish. So if you're not an early riser or willing to sort of put the time and work in, it's going to be a grueler.
No, I think the odd question that I get is well, how much money is it? And my response is, if you're thinking about doing this for money, forget about it. I think anyone in healthcare, there's easier ways to make money if that's what interests you. But it's definitely not and shouldn't be the prime motivator for you doing it. So yeah, but it is interesting, and even though, you know, as we all work in theatres, even though it's the same procedure, perhaps, you know, it can all be very, very different depending on the patient and the surgeon and what can and cannot happen, and that's it for me. That's the love of it. Just
out of interest, and I probably already know the answer to this. Like you say, it's like a different perspective of those same surgery. Do you think that, because it's not to say that we got bored of doing the same surgery, but when we've done the same surgery for many years, it becomes another one of those lists. Did this add a new lease of life or a whole different dynamic, I assume, to the same procedures? Like the lists now look different to you than what they did when you were an ODP, Brian?
Yeah, hugely, because you're looking at it from the giver of the anaesthetic perspective, and you know, there's this talk about sort of progressing from an ODP and into an anaesthesia associate. I think one thing I'm always keen to stress to people is it isn't an extension, it's an entirely different role, and as a result, your focus and your thought process and your responsibilities are entirely different. So perhaps what might have been, shall we say, a bit more of a mundane list as an ODP, after you've done it for, you know, the umpteenth time, is very different when you're on the end of the syringe or the needle and doing it, because, you know, we've all experienced this. Things can take a bit of a turn, you know, very quickly sometimes and very unexpectedly. So yeah, I think it's complacency, doesn't really form part of that for that reason.
So you've already identified, obviously, that you were an ODP prior to doing your training. Do you think that gave you any advantage, or do you think that helped or informed you as you became an anaesthetic associate?
So I think, you know, cards on the table, I wasn't an ODP for very long, as you all know. But when I was doing my ODP training, I was working with a couple of guys who were coming to the end of the PAA, as it was, training. So that was quite interesting for me, and they were brilliant at teaching as a student ODP. And then I qualified and was an ODP for a year. I think it gives you a good head start because you know about theatres, you know what the equipment is, you've seen operations, you understand the principles of how an operating theatre works, sterility, who everyone is, the processes. So from that point of view, I think it gives you a good head start. But do I think it gives you a big advantage overall? I think at the end of the training, regardless whether you have a clinical background or a non-clinical and coming from a more scientific background, you will be just as good. So I think in the long term, it doesn't make that much difference. But I do think, having worked with a couple of biomed science grads coming in who are, you know, at the beginning of year 1 and year 2, I genuinely take my hats off to as to how they cope with not just this crazy amount of knowledge and information, but actually this completely different working environment. And that, you know, they have to learn what ODPs are all the basics. So you take that for granted as an ODP, because and I found it challenging enough knowing all of what I knew. I don't think it matters if you're an ODP for 1 year, 2 years, or 20 years. You've got a bit more experience to draw upon. But ultimately, for me, that's what being an ODP or having some perioperative experience does. It just gives you a good head start to the whole training.
The real question here as well, Brian, is now you are on the other side of and being supported by ODPs. Do you notice the difference now between a very, very good ODP and one that may struggle a little bit with it? Like in terms of being supported by an ODP now, do you notice the ones that are expert? Yeah.
Massively. I mean, you how can I say this politely? Well, to be honest, I mean, there's a few things that you're always listening to your ODP. Okay, it seems a bit of a cliche, but absolutely, an experienced ODP will have something before you might have thought about it, but you might not have asked, and it's there. And that's the difference. And again, because you know things can turn very quickly. A good ODP who's forward thinking and who can read the room and understand what's going on will get everyone out of trouble, regardless of whether an AA or an anaesthetist. You know, and that's where as ODPs we make our money, isn't it? That's where we earn.
Yeah.
You know, everyone can do it when it's nice and easy and passing this and doing that. It's knowing when things aren't quite going to plan and how to do it. So you certainly appreciate a good quality ODP. And I think from me with the lecturing role now, I think that's what I try and sort of, I'm very acutely aware of that and want to instill in people and want to make people who I would want to work with and who I'd want to be sort of looked after by. You know, because I think, yeah, it's I've been saved several times, I think, by a good ODP who's just had the wherewithal to know exactly what's going on.
You always do that little whisper. Do you think you might want to do this? This is, maybe you should consider this.
Absolutely.
Would you like a Goodell?
You know, and yeah, and you know, I've been doing it. I started 10 years ago now, so bit of experience, but I still consider myself, you know, there's still so much to learn and experience. So working with an ODP who's, you know, been around the block, you just think, oh, this is good. You know they're going, you know if they're going to be good and have your back.
So my final question,
I was going to say, isn't that if you know they're going to be good if there's a coffee ready in the morning? I thought that was the rule. If you get in, the drugs are out, everything's prepped, and there's a coffee, you know they're going to be good. I
mean, they're certainly on it at that point, aren't they?
Bribery gets you everywhere, including an early finish. If you bribe the anaesthetist good enough, you get the early finish that you want.
So my final question for you then, Brian, is what advice would you give to somebody that's wanting to become an anaesthetic associate?
It's a really good question. I think it's not the easiest thing to do, but try and talk to people who are in the profession. Try and spend some time going to work if you can, sort of volunteering. A bit easier if you're clinical and you're working within the same trust, a bit more challenging if you're not. But certainly sort of having that time to see actually what the role is about. I think you have to trust the training process. Depending on your background, you have to accept you're going to be completely incompetent and out of your depth. And I think every one of us has felt like that, starting new physically technical skills, knowledge. At the beginning, it was extremely challenging. So I think there comes a point where you just have to sort of go with it and just accept that, this is for the long haul. So I think I think one of the biggest thing for me when things took a turn was actually just accepting the failure of it. What I mean by that is, you can't get a cannula in for however many days in a row, or you can't put a tube in, or this, that, and the other. And somehow you just have to sort of forget about it, learn from it, and move on. And that's where the training and the supporting and supportive nature of the consultant anaesthetists that I've worked with and trained with was invaluable, because they all remember what that was like. So I think get as much in-depth understanding of the knowledge, because there is a lot of misunderstanding about the role. So I think that's absolutely key, and just go into it with a good open heart, and just accept that the challenge is going to be very, very difficult academically as well as sort of physically in terms of the technical skills. And you just have to roll with the punches. I mean, there's no sort of easy way of doing it. You just have to follow the process, and over time you just get better and more experienced. But I would encourage everyone to go for it. I really would. Some people have said, "Oh, I might be an ODP for a few more years, or do this and get some more experience." And I think I just happened to be very lucky at the right place at the right time, where there was an opportunity for this position, and I went for it because I had nothing to lose. Although I didn't expect to get the training position, so I'm very positive about it. I think it's a role which is going to be here to stay. And I think if you like people, we're all in healthcare to look after people, and this is no different in that sense. You get a bit more hands-on and you're able to do a few more things. But I think my biggest advice would be, understand the role, spend some time witnessing the role, and learn to live with challenging circumstances.
Thank you very much for answering all those questions, Brian. It's really appreciated. I don't know about Jenny and Ben, but I've definitely learned a little bit more about the AA role. Definitely
for sure.
what I tell people in the future.
Well, I think for me, there was a lot of myths around the AA role. I unfortunately kind of bypassed it. Being in paediatrics, it kind of happened around me. But there's a lot of myths, and when it was first discussed, I mean, what you've just said was really nice, actually, because you've been open to being quite vulnerable in that and saying it's okay to accept that, because the idea of going back to being the new starter in the room and having no understanding of what's going on scares the death out of me. Well, I did when I was clinical. I've been in that position many a time since. And I think also a lot of ODPs went into this with a practical mentality into the role. So then you get this perception of, well, I'm not smart enough to go and do that. So like saying to, putting it out there to people to just go for it, I think that's, golden, mate. Really good advice.
And I think what I would say, Chris, is if people want to sort of email in or have questions or sort of want to further that on the back of this, then more than happy to sort of answer any specifics as best as I can, or point them.
Brian's going to reply to every single comment,
every
single comment. He's going to be waiting up till midnight, and he's going to put little love heart emojis.
Hashtag Brian AA. We'll get it started.
Brian AA.
Yeah.
Oh, well, thank you very much.
Thanks, Brian.
ODP Reacts. Diddly.
So, welcome to ODP Reacts, where we react to some of those funny videos that you see on the internet. It is obviously, we've already discussed that it is December right now, and we're all in Christmas t-shirts. I've got a little t-shirt, as you can see there. What have you got on, Jenny?
I have got a Santa shirt that I got.
Pizza?
No, he's got a bell. It looks a bit like pizza, but it is a bell. I see yeah, no, it is a bell. Bell, yeah, I got it in LA a few years back when I was in LA around Christmas time, and I saw this shirt and I was like, well, that's happening. So yeah, it's been my Christmas shirt for a few years now.
Yep. This is my my lack of having a Christmas shirt last Christmas, and Jen told me that I needed to up my game, so I went to Poundland. So Jen gets the shirt from LA, I get one from Poundland.
Yeah.
I just told everyone where you lived.
Yeah, good point. Near Poundland.
Near Poundland.
I'll edit that bit out, don't you worry. I'll keep your address under lock and key.
Well, to be fair, if they want to go searching around every single possible Poundland to find where we live.
So we're going to move on to some React videos. So this is an interesting video to react to. The students taking excellent care of the simulated patient. Me putting them into cardiac arrest anyway. Many times.
Don't tell them all our secrets, Chris. Even if they've done everything correct, to be fair though, you never know. You never know. You might have done everything correct and the patient might still go into cardiac arrest, and that's just the way it is. That's the way it is.
It's that face.
It's funny. So that's me every single week when I'm doing, because I briefly mentioned earlier, doing paramedics. I do a lot of ILS and ALS scenarios. And the difficult thing is when you get someone that's doing ALS and they're absolutely nailing it, but you're like, but I need to take this further. And part of the learning from this day is, especially when doing ILS with students, you have to take it to shockable and try, or a non-shock, when you're trying to come up with a scenario that's fresh, new, that will end up in cardiac arrest, and then they manage it perfectly, and you're like, and they see you and they watch you go to the iPad, and before you press the iPad, the hands are going for the pads. You're like, oh, here we go. It's like
they're just aware that this is going to happen, but it's times when you just got to. The point is, it's a learning environment. We've got to take that patient into that.
But I bet you guys have been in the room together where you could see it coming, and Jen's caught your eye and the smile's happened, because I bet you that smile is exactly what she sees you do. She's like, oh no, he's going anyway.
So the worst is when you get when you were never planning to get them into cardiac arrest, but the student has done so many things completely wrong that you are then having to put them into cardiac arrest, because they've essentially got to the point where the only option now is for this patient to pretty much die, and then they might learn from it. So that's when me and Chris look at each other going,
you get the safety on.
Just press this button, this cardiac arrest button.
Like you just mentioned, it's an environment to learn, and it's a safe place to be able to manage those scenarios and to learn from that.
And the debriefing afterwards, exactly.
Exactly. You debrief afterwards. But I mean, my favourite thing was once it was whilst I was doing some advanced life support myself, and one of the anaesthetists came out afterwards and says, "Oh no, I failed." This is why. I says, "I didn't check airway." Didn't check airway, and he's like, and he came out and went, and I would have done. It were real. I was like, but it wasn't, because it was simulated.
But you can imagine that guy, ever since then, every single time, always checked airway. And that's why we do simulation. That's why it's needed, is because the mistakes that you made in sim are ones that you'll never, ever forget, and you'll never then take it into clinical practice.
100%. So my next video that I've got, this one isn't as funny. Okay, so this is my next video that I really liked. That's checking to see if the surgery is almost over. The amount of times, especially when I've been scrubbed, and the amount of times that, like, the anaesthetist, you just suddenly see them peering over to be like, "Oh, we're nearly there," and the surgeon is trying to ignore the gaze.
Yeah,
I've seen it the opposite way around as well. Like when, because in the hospital that I used to work at,
blowing in the window,
shutters. But they'd make such a noise as they opened to be able to view into the anaesthetic room. So then the surgeon would just look and be looking to see what the anaesthetist was doing. The anaesthetist was like, "Do you mind?" And you're like not looking. You're like, "I'm not. Don't make eye contact. Don't make eye contact. Don't make eye contact."
I remember seeing that meme from ages ago that was like, the ODP always starts to panic when the anaesthetist stands up. If as soon as the anaesthetist stands up, you're like, oh, hang on, this is something's going down here. We need to start looking again. But yeah, that looking over the top of the drapes, like, how you doing?
Are you done yet?
Yeah.
It's when once upon a time I used to work in neurosurgery and craniofacial. So obviously surgery is as far away from the anaesthetic as possible. And it's when you get the stand up and the anaesthetist then go hands behind the back and like wander around the top to go, and then come back, usually followed by, should we think about getting the bed? Or I think we probably need to do another coffee run. And there was the two options you were getting at that point.
Yeah.
Always a coffee run.
Always a coffee run.
So thank you very much for joining me for
you.
episode 4 of the ODP podcast, where we've covered the role of the Anaesthetic Associate, and tune in next time to hear more. Thank you so much for listening to us at the ODP cast. We hope that you've enjoyed it, and please remember to save, add it to your library so that you can keep up to date with us. To get involved, follow us at ODP Shoe across all major social media networks. Whether you're listening on your way to work, whether you've got a coffee, or you're just waiting for the patient to be brought down to the anaesthetic room, don't forget to give us a like so that you can see what we're up to next time on the ODP cast.